So we will go ahead and get started. Good afternoon, everybody. Really excited that you're here for our next Avant-garde Health Team Collaborative webinar. The focus for our webinar this afternoon is going to be in a couple different categories. So the first, we'll do some kind of high-level collaborative updates and kind of sharing what CMS has shared with us so far about data that folks have access to and kind of what that means for participants. And then we're going to get into some nuts and bolts of team, going over high-level bundled payments, what it means financially and clinically for, what historically has been an unmanaged surgical episode of care versus what does that look like differently financially and clinically with a managed episode of care. And then we're going to get into all things target price and then reconciliation timeline and process, and going through kind of zooming out high level, kind of the so what behind the logistics of the target price and reconciliation. What does that mean for participants, kind of the time lag, and what are the strategies there? And then we will have an opportunity to talk about optimizing post-acute care placement and performance. We'll have a bit of time at the end for Q&A specifically, but please, as we're going through this content, virtually raise your hand, put it in the chat about what folks may have questions about. So I just wanted to mention that at the top. We certainly don't need to wait at the end when people have questions, when we're like digging into the details about the target price as an example. Excellent. We'll start with some brief introductions. My name is Ann Conrath. I am Director of Sales here at Avant-garde Health. Almost my entire career has been in value-based care. It is a big passion of mine. I'm really interested in it. I'm frankly really excited for team. I have implemented bundled payments across the country, primarily in BPCI, primarily in orthopedic and cardiac bundles. So big area of interest for me, and I'm really excited to help facilitate team and help folks be successful. So really excited that y'all are here in this collaborative. And yeah, we're excited for our conversation this afternoon. Derek, I'll toss to you.
Thanks, Ann. So I'm the CEO and founder for Avant-garde Health, based in Boston. And just as a refresh, started Avant-garde Health 11 years ago in 2014, and it grew out of work I was doing with Michael Porter and Bob Kaplan, Harvard Business School, co-leading their healthcare research. And we've been supporting organizations in bundled payments for the last 9 years since the inception of initially the Medicare CGR program, and then more recently the Medicare BPCI Advanced program.
Great. Thank you, Derek. And my name is Porter Jones. I'm the Chief Medical Officer. Been with Avant-garde for 4 years, based in Denver, Colorado, and I'll echo Ann's excitement about the CMS team program. It's a great program. I think there's a lot to be learned and a lot to be given to the patients that are part of it. It's been about a shy decade in traditional hospital administration, and a good chunk of that was managing and overseeing bundled payments. So very excited for this and excited to learn from this group as well.
Awesome. Derek, I'll toss to you.
Okay. So very excited for this to be our second Team Learning Collaborative webinar, and excited that the group has grown quite a bit since we kicked off the Learning Collaborative in early May. I think the number of participating organizations in Learning Collaborative now is up somewhere in like the about 30 to 35 health system range. And so very excited for the conversation today amongst everybody. And just wanted to mention one thing briefly, which is that for health systems that submitted their paperwork to CMS by early May, CMS shared the initial target price information and historical baseline data with those hospitals a few weeks ago. And then for hospitals that submitted their paperwork by late May, they should be getting that same information this summer from CMS. And then this fall, CMS will be sharing additional refined baseline data and target prices as well. So for context, the initial target price information that was shared and was based off of the proposed Medicare payment rates for the upcoming fiscal year 26 for Medicare. Once CMS finalizes the Medicare payment rates for fiscal year 26, they'll slightly refine the target prices. And the target prices will also be, what was shared initially was based off of 2.5 years of baseline data from January 2022 cases through mid-year 2024 cases. The data that's coming in the fall will include full 3 years of data. So it's going to include the full 2024 data as part of the baseline data as well. So just want to make sure people are aware that there's a lot of information that CMS is releasing right now, and there'll be some refinements and additional information that CMS will be releasing in the fall. And we're happy to do a complimentary initial analysis of that data and target prices from CMS to help you understand historically performance for your organization and to be able to highlight some opportunities for improvement as well. And so happy to connect with people who are interested in that analysis individually afterwards. And then also, yeah, we're having the third webinar in the Learning Collaborative series will be 4 weeks from now on July 23rd at 1 to 2 p.m. Eastern time as well. And so calendar invite went out for that already. And if you didn't receive it, we can make sure to add you to that as well.
Awesome. Thanks, Eric. And then Porter, I'll toss to you.
Yeah, thank you, Ann. Thank you, Derek. As I mentioned, let's get into the nuts and bolts of the CMS team program. There's a wide range of experiences here, but we just want to make sure we level set on even basic items like vocabulary, terminology, what's included, what isn't included. I will highlight this will go out, so feel free to sit back. You don't need to take a lot of notes. We'll send this information out. And on the Avant-garde website, we have numerous CMS team blogs that gets into some more of the nuts and bolts of this information if there's a specific item or topic that you really want to dig into. So we want to provide you with as many assets and learning platforms as possible as you prepare for the Jan 1 start date. But just to begin and go over the overall program, as we look at this, some of these, just looking at the overall program in general, bundled payments, we want to make sure that it's clear that from the moment that that patient steps foot in the hospital, all the way out to 30 days post-discharge, that is what is included in the scope of CMS team. The anchor hospital you're going to see a lot. That is the hospital that initially intakes and actually sees that patient from the initial start date of that procedure. And then the triggering event. We're going to talk about this, and I want to go back to this because I think this is one of the most important aspects of managing appropriately this program and being successful. But it's all based on what is coded and billed and sent to CMS once that patient hits your doors. But we'll go back to that in just a moment. Episode timeline, again, it's 30 days. Everything that occurs post-discharge for the next 30 days. We have 5 initial episodes. I won't read these through. I'm sure everyone's familiar with that. But as we move on to the right side of this slide, I want to make sure that everyone really understands what is and can be included. So that's all of the costs that go on in the hospital. That also includes the provider costs, the physicians, the anesthesiologists, all the providers that are part of that. It includes all of the post-acute care. So we're going to dig into that a little bit later during this webinar. But whether the patient is going to a SNF or getting home health care, et cetera, those costs will be included. And then any sort of outpatient services. So I think it needs to be very clear. You have an ED visit, you have additional labs or imaging done. That's going to add to that cost. And even DME or durable medical equipment that is prescribed or provided to that patient, that will also be thrown into the mix. So just to be very aware of everything that goes on and what actually is part of that box that is going to be calculated against that overall anchor price. Going back to the triggering event, you may not be told or know once you submit for billing whether that patient is part of the CMS team program for a month, 3 months, et cetera. So we highly suggest that you internally optimize on being able to flag that patient based on what is scheduled, or you work with a third party that is able to help you out with that. Why is this important? We want you to be able to optimize as these patients are being scheduled and coming in, who is actually part of the program. Are there any sort of pathways or education or care provided that is going to be different for those patients than others that are coming in? Ideally, and I think the hope of this program is you begin optimizing all patients to be as efficient on both quality, cost, and outcome. But we also understand there may be a learning period. And so we want you to be able to be very clear of who is coming in and how do you need to look at some of these patients slightly different. I know, in my past, we have different pathways slightly for all sorts of patients, uninsured patients, celebrity patients, and we would have flags within the EHR that would pop up. So we knew, if we needed to do anything different. So we want you to be as clear as possible as who is part of the program and what needs to be done for that group.
One thing I was going to share here too, Porter, is on the Part B drugs and biologics. So this is something that we really want to dig into for hospitals that are in the spinal fusion clinical episode. I know that in BPCI, this was sending having episodes go over the target price because they didn't realize that the surgeons were using such expensive biologics. So that I just wanted to flag that is something that can, and not even having a healthy patient, they go home right after surgery, but that can be over the target price because those biologics are so expensive. So that's definitely something that we'll want to dig into for folks that are doing spinal fusions, and seeing kind of what the surgeons are using today in your baseline, and then wanting to make some potential adjustments moving forward.
That's great. Thank you, Em. So let's go through we're going to go through two patients. These two patients could theoretically or relatively be the same patient, same procedure, and one that is very unmanaged and one that is highly managed. And again, this could also go back to understanding that patient is part of the program and getting flagged very early on in the process. We want to be able to go through all sorts of, discharge disposition planning, any sort of risk mitigation. But this is a great example of a patient that is unmanaged, is scheduled for a procedure, part of the team program. As you're going to see between these two patients, the anchor stay or the hospital cost and the Medicare Part B cost is relatively the same, stays pretty much consistent between the two patients. But then where it begins to deviate is going into the post-acute care once they leave the hospital during those 30 days. So you see this particular patient spends about 12 days at a skilled nursing facility, which costs $10,000. Another 13 to 14 days in home health, which is $2,500, and then a few days on the back end at outpatient physical therapy. So when you're looking at a target price of $25,000 and you see the overall, which is $29,900, you are well past that target price for this unmanaged patient. So as we go to the managed patient and hopefully someone that is flagged, there's been risk mitigation going on, there's been some discharge planning already occurred. Again, you'll see hospital stay, Medicare Part B stay, relatively the same in regards to overall cost, but this patient is now going to home health, which is $2,500 compared to what we were spending previously, which was around $12,500, and then outpatient physical therapy at $750. And obviously, neither of these pathways include, did the patient have to go to the ED did they have to be seen for anything else? So there's a very big difference in regards to cost structure, and I think outcome as well for the patient, whether they are being managed appropriately well before they even arrive for their procedure, compared to just showing up and going through a process that is relatively unmanaged. So wanted to go through some examples. Again, we can get into details, but wanted to make sure that it was very clear what the pathway of that patient can look like and should look like.
And then on this topic, someone asked a thoughtful question of, is there a bonus cap in place? Yes. So depending on your risk track that you select, and we're going to get into that here in a second, but yeah, there is going to be a bonus on how much money that you can make in the program, each performance period.
Most definitely. Thank you, Em.
Cool. Thanks, Porter. So we're going to get into reviewing the target price methodology as well as the logistics of reconciliation. So when you're participating in a bundle payment program, you want to understand how CMS is creating the target price, and then more importantly, what aspects of those components can I control? So starting in the upper left-hand corner, the target price is going to be primarily based on regional data. And CMS is using the 9 US Census divisions to determine each region. And so the target price is going to be the regional average expected spending for all items and services provided to a beneficiary during an episode for a given DRG or HCPCS code. So what goes into the target price? So the first thing is that benchmark price. So this is the average clinical episode spending in the third and final calendar year of the baseline period. So as an example, your final target price for performance year one, which is going to be 2026, they're going to use regional data from 2024 to make up that regional benchmark price. They're going to scale, they're going to Winsorize, which Winsorize is just, they're going to cap the spend on cases that exceed the 99th percentile in terms of spend within that region, and then they're going to standardize the data. Next comes the trend factor. So this is applied to account for changes in overall spending patterns between the final calendar year of the baseline period and the performance period. So we're trending the dollars forward to the current performance year. Next comes normalization. So this is a value used to adjust data to get it to a standard range. And in the case like they do in Medicare Advantage, it's used to adjust risk scores. What we saw in CJR is that the normalization factor and how they were calculating it previously really wiped out any positive effect from risk adjustment. So the good news is that CMS is making an attempt to address that issue by allowing each region to have their own normalization factor, and it's going to be calculated at the DRG and HCPCS level. So they're going to normalize using the benchmark prices only, which is the raw regional average episode spending before applying any trend or discount factors. Risk adjustment multiplier. So this component accounts for variation in spending due to patient and hospital characteristics. I have a designated slide to talk about this specifically that we're going to get into next. But this is a part of the target price that is hospital specific. And then the final piece is the CMS discount factor that's applied to make sure that Medicare gets their cut of savings in the program and for each episode. And then going into the upper right-hand side of the slide, the preliminary target prices. So as Derek had mentioned, everyone should have received these files from CMS. Of course, if you submitted the documentation to get the data, but it's two values. So what's really nice is that we can see what's the regional average target price, and how does my hospital-specific target price compare to that regional average? So I have some caveats there of what's included and what's not for each target price. But this can be really helpful just to understand where you compare for each DRG at each facility compared to that regional average. And then the final target price that you'll receive during reconciliation is going to be unique to your hospital for every DRG and for each HCPCS code. And as Derek had mentioned at the top, so this is based on the 2026 proposed rule. Things will change and update in the fall when they finalize the 2026 rule. Just checking here for any questions that are coming up. The target price risk adjustment factors are listed here. These are going to be unique to each hospital. So the hospital factors are going to be safety net status, bed size, beneficiary social risk factors, Medicare and Medicaid dual eligibility, qualification for Part D low income subsidy, and the community deprivation index. So this is just a way, like the CDI is just a way for CMS to gauge socioeconomic status for patients based on zip code. Which can be a helpful factor. And they think that's why they moved it from the CDI away from the ADI, which is the Area Deprivation Index, just so that it can be a bit more specific and a bit more accurate in assessing what's going on socioeconomically with your patient population. And then the beneficiary characteristics. So this is why the comprehensive pre-op risk assessment is so important for your elective procedures. You want to not only be documenting all of your patients' comorbidities, so CMS understands the risk profile of your patients, but then you're also addressing all of these areas of your patient's health. You're making the appropriate referrals. You're helping coordinate their care. You're potentially delaying surgery if they have a hemoglobin A1C of 9 and they're not consistently seeing their endocrinologist or their PCP, as an example. So this is why bundled payments work to reduce the cost of surgical care, because now care teams and surgeons, you're incentivized to take care of the whole patient instead of just one specific body part like it's been in the past, historically within our healthcare system. I want to call out specifically the hierarchical condition categories or the HCCs. So this is how CMS is identifying your patient risk. So the look back period is 180 days from the start of the clinical episode. So what that means is that CMS is going to look at that time period, the 180 days prior to the clinical episode, to determine that patient's risk score. One final thing to note here is that the risk adjustments will be calculated for each hospital and DRG or HCPCS episode type. And then if folks have questions as we're going through this information, please virtually raise your hand or enter it into the chat. I'm monitoring that as we go through. The performance track. So the hospitals can choose from. We won't spend a lot of time here since we've reviewed this information before, but the biggest difference in the track options is your up and downside risk. And if your hospital has a special designation, like a safety net hospital, where you're protected from greater financial risk. I will spend here just a moment because there was a question from the group about what's our cap on how much we can make per performance period. So that's listed here. So as an example for track one, which everyone can do performance year one, there's no downside risk, but there's a cap on how much you can make, which is going to be 10% of your NIPRO. And we're going to get into like what that is, but it's essentially 10% of your bonus of what you have, over the below the target price. And just looking at this question from Jacqueline. Thank you for submitting it. For beneficiary acuity HECs, specific HECs written there, is there a list of what categories will apply? Yes. Is the HEC count also only specific to categories? We do have CMS did give us the HCCs for each clinical episode.
So it's different per episode.
Yes.
Oh boy.
And I debated, Jacqueline, whether to put that on the slide. So I'm really glad that you asked. So I will put that, I will make
Maybe
sure
an
that that
appendix.
is in the resources for folks so that you know specifically what to look for.
Thanks. In the previous slide, there was an HCC count, and then there was also HCC.
Yes.
Then it said specific HCCs. So are they using both a count and the actual score? Both of those things?
From my
Or just the count?
understanding, the specific HCCs are the ones that they have stated that they will be taking, that they will be looking for. And then they will be counting of your patient, how many of those HCCs, how many does that patient have?
Okay, not using the actual score, so the RAF, like the risk adjustment factor.
This is something that we can do, replicate their methodology and just using the historical Medicare claims data we have right now, like do an initial view of compared to other hospitals, how good you're doing today at capturing the different HCCs for each of the different relevant clinical episodes as well.
Okay. Okay, yeah, we have a lot in place to help with CMS HCC risk adjustment factors, but it's across all chronic condition categories. And so trying to figure out how do we adjust that to make sure we're focused on this time period and the right categories.
Yes. And I did look at that, Jacqueline, just because I was looking at them myself of just what the HCCs were. And I imagine if you have those processes in place already, that you're already, likely like ahead of the curve. Because it's like, if the patient has diabetes, documenting that type of thing. But I will definitely share the specifics there, 'cause that's a great question.
Thank you very much.
And then a question from Dr. Cowan. Is there any more granular information on the beneficiary conditions contributing to the risk adjustment? Granular information on the beneficiary conditions.
Is that maybe the same question?
It's the same, yes.
Oh, I'm sorry. Okay.
I was typing that as the question.
Okay, thank you.
Yeah, very interested, very interested in more detailed information as we've been saying.
Yes. Okay, thank you. Excellent. Wonderful. Well, yeah, so with the risk tracks, this is Yeah, nothing a lot more to say here is just that, each hospital can choose their own risk track. So I know we have a lot of health systems that have multiple hospitals. Each hospital can choose their own risk track. And so we'll be looking at this opportunity, what this looks like for all collaborative participants when we get that updated baseline data in the fall. All to say is that these are going to be our options. Hmm. Good question, Dan, on the CDI versus the ADI. I don't know the SVI, and I do not know the specifics on that, but I can share with you the resource that I have on why they chose to do it. And from my understanding, it was to more accurately assess the risk in urban environments that the ADI did not take into account, from my understanding. So I know that's like high level, and you might be interested in more details there. But I can share with you the resources that I have, if that's helpful. Okay. The quality measures for team are outlined here. All of them are claims-based measures except for the total joint PRO measure. So a bit of information on the PRO measure. So that's the preoperative data that needs to be collected 90 to 0 days before surgery. And then the postoperative data needs to be collected, I think, 270 up to 427 days after the surgery. And then hospitals need to submit data for at least 50% of their eligible patients to meet that reporting requirement. So I know that there's been questions there since that's the one that I know hospitals have measures in place to address almost all of these on the slide, but that PRO one I know is new. So just wanted to share a bit more information there. And then the quality measure score. So CMS is going to convert your quality measure scores into scaled scores by comparing them to the national percentile distribution for the calendar year 2025. So where do you compare nationally and what percentile do you fall into? So that's going to include all hospitals and not just team hospitals. The timeline of when hospitals are going to receive your quality measure scores, those are going to be at the beginning of the next year following your performance period. So you'll get your quality scores in the beginning of 2027 for the 2026 performance period. How much your composite quality score impacts your reconciliation depends on your risk track. So that's going to be outlined here. CMS does take into account your episode volume and then adjusts your score accordingly. So your higher volume clinical episodes are going to count more. They're going to carry more weight than your lower clinical, your lower volume episodes. So I think helpful when folks think about allocating, appropriate resources and effort. Certainly your higher volume episodes would be the ones where you want to spend the most time. Reconciliation timeline and process. I'm just looking at the question posed from Ben. Yes, we can share more specifics there on the time frames. Yes, I will share that in our follow-ups. Thank you for asking. Reconciliation timeline and process. So reconciliation is going to occur 6 months after the performance period. The payouts and repayments are going to be in one lump sum. And then to calculate your NPRA, which is the net payment reconciliation amount, one of the really fun acronyms to say in bundled payments, in my opinion, that's your final amount that you either are going to receive from CMS or what you're going to have to write on the check to CMS if you're over that target amount. And they're going to apply all of the final components there that I have outlined. So one thing I want to share here is that because there is such a significant lag for the payout in team, I mean, we're talking 18 months after you start the program, data analytics is going to be your greatest asset. It's going to be your best tool for engagement with your clinical teams to keep the momentum going for building out those care pathways. And because we're able to ingest EMR discharge data, because we have financial and utilization prediction models built into our team analytics, this is how hospitals are maintaining that tight feedback loop with clinicians and surgeons. They're addressing outliers in real time. You're building that flywheel of a value-based care mentality when for surgical care because the financial rewards for this program are just few and far between. So using the data to monitor your progress and celebrate the wins along the way, I know has been really helpful for hospitals to really keep the motivation in doing this work. I know we have a couple questions that are coming in from the chat. Will regional target prices be based on only hospital-based costs, or would that price also include the costs for patients who had their procedure at an ASC? Yes. So they're based on no. So it's going to be the target rate. You'll have a unique target price for your outpatient procedures, which would be HCPCS code, versus your inpatient procedures, which are going to be DRG based. You will have two separate target prices for those clinical episodes. Occur before, will the quality adjustment occur before or after the cap of 10% or 20% of the target? Great question. I think it's before. That's a great question, Jacqueline. I want to double check my notes before I say.
Okay.
Yeah.
Sounds
Yes.
good. And I thought and I could be wrong on this, but I thought our preliminary target, this is going back to Dr. Cohen's question.
Yes.
You said that there were separate targets for the HCPCS versus DRGs, but the preliminary target files we got mapped the HCPCS to DRGs and then had a target. So I guess I was assuming that the targets would be the same for the same DRG at the same hospital.
It will be
and then it would include any HCPCS that had been mapped to that DRG.
that DRG.
But maybe that's an incorrect assumption.
Let me take that back to my data scientist and double check.
I think Jacqueline's correct there.
Okay.
That it's CMS and the initial files. There's one item, for a DRG that includes the associated CPT codes of that case is performed outpatient.
Oh, yes. Okay. I'm following now. Yeah, yes. Okay. Yes.
And then, sorry, one more thing. I think Dr. Cohen's question was actually, do those targets include ambulatory surgery centers outside of the hospital entirely, right? Is that what you were asking?
Right. Yeah.
Oh,
I'll clarify. So in our community, and in a lot of communities, you might have an outpatient joint replacement, for example, and you could have that procedure at a hospital or you could have that procedure at an ASC. And typically, the more complex patients have those procedures at hospitals. The less complex patients have those procedures at ASCs. So my question is the blend of your community's ASC versus hospital site for outpatient procedures in these bundles going to impact your target price?
If I'm understanding the question correctly, your patients that have a surgery at an ASC are not going to be included in the bundle.
Right, but okay. So their costs won't be impacting the target price, the regional target prices.
Correct.
Okay, that was my question.
Yes. Thank you for breaking it down for me. Okay. Excellent. Thank you for these questions. I wanted to talk through the waivers briefly that are allowed in team because these can be a great resource to reduce cost. So the SNF 3-day waiver, where you can send a patient to skilled after 3 midnights. I don't see a lot of folks using this just because really if you can keep a patient an extra day, they're getting a little stronger, they can get a little bit more therapy and then they can go home. That's really the preferred strategy in avoiding skilled altogether. The geocodes are waived to bill for a telehealth visit. You can do post-discharge home visits, and then the in-kind services connected to medical care. So if you're doing this, you want to make sure that you're going to get an ROI. But one example I did want to share that I have seen have been advantageous as a strategy to avoid a patient going to skilled is paying for assisted living facilities. I think what I've seen previously is, negotiating $125 to $150 a day, where a patient can go to a respite room, they have available outpatient PT, and the patient can stay there for a few days, if they can't go home immediately after surgery. So the math here would be that, that service would be like $650 as opposed to $8,000 if the patient went to skilled. And the benefit would be that you would make that up on the back end during reconciliation, where you're $5,000 over the target instead of being or $5,000 under the target, as opposed to being $1,000 over the target, as an example. Gain share, you can do gain share in team, and I know this was a thoughtful question that was asked previously. You don't have to proactively send that contract to CMS, but it does have to be available if they request it. Wonderful. Well, we are going to move on to our next topic of optimizing post-acute care placement and performance. So I am really excited to introduce our colleagues from WellSky who are presenting during this next portion. Bridget McGrath, she is the COO of Payer and Emerging Markets and the General Manager of PAC Advance. And Tommy Gautreaux, who is the Director of Clinical and Solution Architecture with WellSky. So without further ado, I will turn it over to you, Bridget and Tommy, to take us through this next topic.
Excellent. Thanks, Anne. All right. I will share my screen here. All right. You should be able to see the slide deck, optimizing post-acute care.
Yes.
Excellent. All right. So thinking through strategies and optimizing the post-acute care, as Porter mentioned at the onset, having visibility and understanding who are your patients that you're trying to target and manage, and hopefully, I think Anne said, hopefully you're strategizing across your entire patient population, but knowing this is a specific patient population that you need to focus on, it's really important that your care team in your acute care facility or outpatient setting in your acute care facility know who those team patients are, but then also sharing that information with the post-acute care partners that you're collaborating with. So being able to have a systematic mechanism of sharing that information out, be it on a referral as you're sending those out, or in some sort of solution that you're collectively using to manage those patients, is incredibly important because as we've talked about now that, the spend is monitored across the 30-day bundle or episode period. So you have to be able to have that visibility for that entire 30-day period, no matter who is touching or interacting with that patient. So the visibility is very important. The next piece that I'll mention is intelligence. So utilizing tools to help identify the most appropriate next site of care is one item that is very beneficial. Utilizing different risk models and scoring tools for patients that may end up in the post-acute care setting, understanding an expected length of stay, and then having visibility into if the patient is more appropriate for hospice or palliative care, end of life, and that sort of thing. For just overall quality of care. So various tools available, and we'll expand on some of those. And then finally is the action. So taking the action. So you've got the visibility, you've got the intelligence and the different models to help inform what you're doing. But now it's how do we devise and come up with actionable strategies for managing the outcomes for our team patients. So, making sure that you're collaborating with your PAC partners and working with your patients and families over that 30-day episode window to really deliver that high quality care. So thinking about diving a little bit deeper in some of the specifics here. So thinking about the strategies that you can use kind of in a few different buckets. So starting with the hospital discharge planning process. So again, making sure that the team patients are clearly identified to your hospital case managers, social workers, is really important. And driving those patients to the PAC partners that are, really high performing for SNFs, home health, et cetera. So one is ensuring that you have developed a strategy and identifying your PAC partners. And we'll talk a little bit more about that in a moment and some different the ways that you can do that. But identifying that high performing pack network, ideally diagnosis specific, looking at these specific diagnoses that are part of the team model, is really important. And then, coming into the kind of the intelligence piece is using some decision support tools. So, listed a couple examples here, but there are a variety of different ones. Epic has risk scoring, 6 clicks assessment, LACE assessment. And then within our WellSky solutions, we have a variety of tools as well. And then, making sure that you can highlight those high quality partners as you're providing a list of patients for patient choice, making sure that you're highlighting those high performing SNF and home health agencies, and making sure that your patient and family have a good understanding of what that means for them and how going to one of those facilities could result in better outcomes for them. So that's all thinking through kind of the guided hospital discharge process. Now, once the patient is outside of the four walls of the hospital, we're looking at, the PAC episode optimization. So, ideally, if we can avoid, SNF as a higher cost of care, getting those patients to the most appropriate next site of care, and lowest cost that can provide the appropriate care for them. But if you have a patient, that's landed in the SNF, having that visibility into the SNF stay. So one, the SNF knowing that the patient is part of your team bundle program, but then also having visibility into the length of stay in the SNF and clinical information in the SNF. So really understanding, what's going on with that patient while they're in the SNF and setting appropriate expectations from your care team, is really important. Understanding, when the patient is going, if the patient goes back to the hospital, and managing that readmission risk. So knowing, that the patient is there, if you're following as a care coordinator, making sure that the SNF, has contact information for you and your providers as the care coordination manager, and really trying to prevent those readmissions proactively, versus, trying to react once the patient has shown up back at the hospital or that sort of thing. I mentioned some models around end of life management and that sort of thing where applicable. So that's important to know, to understand, and be able to coordinate and collaborate with the care team around that. If your patient is going directly home, working with those home care agencies, understanding timely start of care. So the biggest risk around readmissions is around the times of transition. And if you have a patient that's supposed to be going home with home health, and knowing when home health actually shows up, and if they didn't show up on day one, proactively reaching out to that home care agency or to the patient and family, and ensuring that the patient has what they need to prevent that readmission or showing back up at the ED is really important. So the technology piece of the visibility into the SNF stay, as well as the home health episode, is really important, can be beneficial in managing these patients. And then coordinating with that care team in the post-acute, so in the SNF, or with the home health care agency, having a method of communication. Is it an in-application chat within a third-party solution that you're using to coordinate that care, and share information, can be really beneficial. And then again, having visibility not only into the ADT and tracking of where that patient is, but having visibility into the clinical information during the stay. Know what's going on from a progress perspective with that patient, and are they tracking towards their expected length of stay, and managing cost is really important. And then, moving to now beyond, maybe your patient's going directly home, or maybe they're going from the SNF to home or home with home health. So understanding that readmission risk, knowing that the highest likelihood for readmission is going to happen during those transitions of care. So understanding that and having visibility into real-time information as your patients are making that transition. When was my patient discharged? Who are my patients that were discharged yesterday if they're going directly home? So I can outreach to that patient and family, make sure that they have what they need, that they were able to get their medications filled, et cetera. And then as they're transitioning even from levels of care. So if you have a patient going from SNF to home with home health, again, having the visibility to know that that transaction has taken place and following up with that patient. And, prioritizing your outreach to the patient. So depending on the volume in the different episodes, you may have a number of patients that it might not be feasible to touch all of them. So having readmission risk tools to prioritize out appropriate patients or your highest risk patients, again, very, very beneficial and can help drive workflow and success within your patient management. So what you're seeing here is an example of some tools that are available in a number of third-party suites. This happens to be a look at some of the tools in the CarePort suite, but having the risk tools and the warnings visible, being able to be visible and delivered to your care team in a timely manner. Not only knowing when your patient is admitting and discharging, but understanding the risk. If your patient is in the SNF, do you have visibility into their vital signs? How are they tracking and trending? If they have a comorbid condition of heart failure, can you see if they're trending, how they're trending with their weights and that sort of thing? So that level of visibility allows for collaboration with that SNF to really proactively manage your patient and try to mitigate readmissions. Once you have that information, how do you collaborate? So I mentioned, that bi-directional chat or communication with those post-acute care organizations can be really important and easy way of managing without having to do phone calls or trading emails, et cetera. And then the visibility into the real-time data. So not only, as I mentioned, the admission, discharge, and transfer data, but also that real-time clinical data to truly understand and know what is going on with your patient, give you that visibility into the treatment and the care plan and how the patient is progressing, through some of these tools can be really important. And then finally, the care plan and monitoring the patient. So hopefully you have your own solutions and teams that can manage that patient, or using a third party to help you track and manage your patients through transitional care. Again, really, really important and keeping a proactive approach and mitigating, points of failure and increasing cost. And then the last thing that I wanted to touch on here is building and maintaining your post-acute high-performing network. So, we have highly accessible form of information is the CMS data, the quality data, star rating, that sort of thing. And that is a good, data set to look at. However, understanding that data most times is quite lagged. You're looking at, 3, 6, 9, 12 months old data. You're looking at data that is by nature focused a lot on custodial or long-term care patients and less on the short-term patients that are there for a rehab benefit and moving back to the community. So CMS data is great, but also having some visibility into real-time performance data, focusing on cost, quality, and utilization for both a SNF and a home healthcare agency is really important as you're building out the network to make sure that you are building the network based on quality and performance that is current and up to date. Anne mentioned before, the gain sharing arrangements. And so that's another opportunity that you can explore with your high performing partners is, or bringing them to the table if you have a partner that tends to receive a lot of these patients, to really get them on board, to get their buy-in, look at executing gain sharing agreements to build that partnership, from the home healthcare agencies, getting those on board, those organizations on board, and maybe it's talking about a strategy of front-loading visits to drive patients home, that could be on the fence, and so some different options to deploy there. And then once you've built that network and you are now have that network that you can share with the patients and families as you're doing that discharge planning, now it comes to performance monitoring. So the ongoing monitoring of your patients and how they're performing, not only at the high level, but at the individual, you could do at the individual patient level and also at the individual episode level within your team model. So understanding for the SNFs, the real-time length of stay, how are they performing? How many patients are they sending back to the hospital, ED observation, inpatient, et cetera? and having that data, in a more real-time manner so that you're not waiting on historical claims data or your claims data to come back is really beneficial. From the home health care perspective, I've, belabored the start of care and how important that is at getting a timely start of care, but then also understanding, the rehospitalization data, how many patients are going back to the hospital once they've started that home health care episode, either to the ED or being admitted. And then finally, it's great that you have that data and hopefully you have collaborative discussions, quarterly meetings, monthly meetings, et cetera, to discuss this. But if you can provide visibility of this data to your high performing network in real time so they can kind of do their own management and policing of this as they are, looking at their performance and being able to drill into the specific team patients if that's the gain sharing arrangement that you have or the agreement that you've set in place that they're going to care for. So not relying on you to push the data out to them, but having a mechanism of sharing that data or ideally a platform where they can visualize that data in real time. So I know I spent most of the time talking. Bridget, I'll kick it over to you to see if there's things that you wanted to touch on or elaborate on.
Thanks, Tommy. And as Tommy said, we think a lot of these data tools and insights are going to be really key to maintaining your oversight of the team model, especially when they're not in the hospital walls anymore. It's that visibility when they're discharged for that 30-day episode. So a lot of these tools will really be able to help you. We also do suggest partnering with some of those facilities on some services models where you either have a clinician that's on site in your high performing facilities that there's a large amount of discharges to, engaging with those potentially those patients that are having elective surgeries for those specific DRGs and doing maybe a prehab view. And what we found really effective here at WellSky is with our clinical services team is really engaging prior to those surgeries or as soon as they're scheduled. Even if they're coming inpatient and aren't outpatient, engaging with them, looking at the disposition post-discharge, educating about the disposition post-discharge, all the services available to them, and then driving to those high-performing networks where appropriate if your members and patients are going to need post-acute care services. And happy to talk to you about those if there's any interest as well.
Excellent. Thank you so much, Bridget and Tommy. Thank you. One final thing I wanted to share with the group before we adjourn, and something that I'm really excited about. We've gotten a ton of inquiries and questions about care protocols and care pathways, and that being a real key thing that folks are wanting in this collaborative. So, of course, with the collaborative and the spirit of sharing, collaborating, knowledge sharing, this is something that we wanted to kind of kick off with this group. And being able to collect care protocols and care pathways from our collaborative participants, and being able to collect those with the purpose of anonymizing those protocols and then sharing them with collaborative participants. Of course, with the whole goal that this is going to improve care for folks. And we know that it does. And so having something that's standardized that we know is evidence-based, I think is going to be incredibly beneficial. And so organizations that contribute will receive access to the resources. And I want to put a star there because I know that a lot of folks are just getting started on their bundle payment programs, and that y'all need these resources the most. And so just want to say, if there's anything that you can share that would be beneficial to the group, and I know that there is. I know that everyone here has something to contribute that will be beneficial for this collaborative that we can all learn from each other. So if folks do have things to share, highly encourage that you do. Please send them to me directly, and then I will anonymize the information and the resources. I will upload them to our Google Drive, our team collaborative Google Drive that is shared with all of the collaborative participants. And I'll again share that link again via email for folks. But I did want to share that we're really excited to offer this initiative, kind of be the harbor of information and facilitating that information to the larger group. Awesome. And so as we wrap up here together, just kind of upcoming events, we, as Derek had mentioned, we're really excited that CMS has given at least preliminary data to participating organizations to kind of get a head start in analyzing where you stand compared to that regional average, and then analyzing the baseline data that you have been given today. You know, what are trends that we're seeing there? So we'll definitely be reaching out to everybody to schedule time to talk further on that. The Care Protocol Resource Initiative, I'll include this all in my follow-up as well, but just want to reiterate here that I really encourage folks to share what they do have, just in the spirit of helping, you know, promote care. You know, in my opinion, no need to gatekeep something that's working really, really well for your organization, and know that it can benefit other organizations. So definitely, please take us up on that, and sharing the information that you do have. And then we have our next webinar that's scheduled for July 23rd at 1 o'clock Eastern. So that should be on y'all's calendar, but I'll, you know, make sure that anybody that doesn't have it, I want to make sure that has it, and please forward it on to other folks that want to participate as well. Wonderful. So any other questions from folks that we can address here this afternoon? Okay. Lovely. Well, thanks again to our colleagues at WellSky for presenting on information that is so important just in that post-acute care space. That's everything in bundled payments and managing patients beyond the four walls of your facility. So really grateful for y'all that you had a chance to present here today. I hope everybody has a great rest of the Wednesday, and excited to see you soon. Thanks so much.
Thanks all.